I think I should have asked something today. I'm asking whatever people are coming in. Hi, Dr. Chong. Good morning.
Good morning. I'm in Guangzhou, in China.
Okay, so Dr. Chong, welcome. We are making the session live now.
Yes.
Okay, so good morning, everyone. We are meeting on 28th of June, 2025, and for a very, very important session. To conduct this session, we have Dr. Meenakshi Verma, a pediatrician and adolescent health specialist at Sparsh Clinic in Punjab, India. She holds an MBBS and PGIMS degree from Rohtak and an MD in Pediatrician from PGI Chandigarh with an advanced certification of adolescent health from RCPCH UK. She's a life member of AHA and IAP and also an authorized and medical practicing focusing on adolescent obesity, diabetes, menstrual health, and screen time. Her core interest includes childhood and adolescent obesity and vaccination. I welcome her over here to talk about very important topic. Ma'am, over to you.
Thank you. Thank you so much. And good morning to everyone who have joined today. So I'll be discussing this very important topic today, adolescent obesity. Obesity in adults, we all have been discussing. But why is it that we are discussing adolescents separately? Because adolescent is a different lot of population. And the management is different for each one of them. So without much delay, let me start with the topic. Let me share my screen first of all. Yeah, I hope it's visible to everyone.
Absolutely.
So let's proceed further. Adolescents, as we say, a group of people who are between 11 to 19 years of age. So they are neither children nor they are adults. So we can say that they are not little adults. They are a different group of population. Why they are different? Because the changes which have been taking place in them, the changes of puberty, all those physical, psychosocial, cognitive changes that have been occurring in their body and mind, they have a lot of impact on their overall health. And why are we interested in treating these adolescents as a separate group of population? Because they are an important window of, this phase is an important window for laying the foundation of a good health in adulthood. So the child which you have been seeing here, he was probably the world's heaviest teen. He is from Delhi, but fortunately he is now improved a lot. Back then in 2017, he weighed around 250 kilos. Yes, and he was not able to see, he was not able to walk because of his weight, he was not able to go to school, he couldn't accomplish his studies. So when he walked to the hospital, he was in a wheelchair. And he was treated with lifestyle modifications, with drug therapy, with surgery. Now he has improved a lot, but this indicates that yes, adolescent obesity is a global serious health challenge because this population, the adolescents, they are the foundation for the progress of any nation. And obesity brings with itself very serious health outcomes, including comorbidities and mortality risks. So it is important to analyze the causes of obesity, to evaluate for the comorbidities, and to identify the best prevention as well as treatment strategies. And that's why we are here discussing this topic. Going by the stats, World Obesity Atlas in 2023, they have found that there are around 175 million children and adolescents who are at present living with obesity, and number might have increased by now in the last 2 years. So it is rising way faster than it is there in adults. WHO data says that from 1990 to 2022, in these last 3 decades, the prevalence of obesity among children and adolescents aged 5 to 19 years has worsened by 6.3%, from around 2% to 8%. So it has increased 4 times. How exponential is the rate we can see? So the prevalence, global prevalence of overweight and obesity combined in children and adolescents, adapted from the World Obesity Federation, calculated in the year 2023 among the boys as well as the girls, we can see that how high is the prevalence of obesity all over the world. Probably we can see that no country is spared where the prevalence is very, very less. All of the countries' prevalence is increasing at a very high and alarming rate. Lancet has published this year, March 2025, that about more than half of the adults and a third of the children and adolescents are predicted to have overweight or obesity by 2050. And if we won't act now, we can't prevent a complete transition to global obesity. So we have to act now so that it's still possible for us to save our adolescents and hence to save our nation. Let's see how this happens. How is it that the obesity rate is increasing and why is it increasing? What is the pathogenesis behind this global pandemic? We have an energy balance equation, a balance between the intake as well as the expenditure. And this is not all about only the food, but all the things which are occurring in day-to-day lives. Intake means hunger, satiety. So a balance between an hunger and a satiety is a must for regulating the food intake. Hunger, if it is more, food intake is more, and if satiety is more, food intake will be taken care of with the society. But when this balance is disrupted, the hormones which take care of this balance, the ghrelin as well as the leptin hormones, we'll be discussing it in our next slide. The balance between these two hormones is very important to regulate our food intake. Food composition also plays a very important role. Different food items, they have different composition and hence different energy capability, and thereby the nutrient absorption is also different in different individuals. The absorptive capacity of one individual for the same food will be different from the other individual for the same food. Why? Because there's difference in gut microflora, there is difference in their basal metabolic rates, and because of all these factors, the food intake for the same food item can have a larger impact on one individual and a lesser impact on the other individual. So nutrient absorptive capacity also plays a major role in this balance. Expenditure, if we talk about the metabolic rate of an individual, it decides the expenditure of the energy which is being spent in the form of food digestion and other activities. Thermogenesis is again the thermogenic capability of the food of the person itself also affects this balance. Exercise, for sure, exercise will increase the expenditure of the energy and hence will help in maintaining this balance more. NEAT is non-exercise activity thermogenesis. So all those activities except exercise, except sleep and eating, all the other activities, they are included in NEAT, non-exercise activity thermogenesis. Simply walking, simply fidgeting, or simply typing on the keyboard or screen, or doing something, some activity or the other will contribute to this expenditure. So we need to maintain this balance, and wherever the balance is disrupted, if intake is more, expenditure will be less, there will be fat deposition, adiposity will take over. If expenditure is more and intake is regulated, then this thing will not happen at all. So this was what I was talking about, the balance between the ghrelin and the leptin hormones. It's like a seesaw balance which the children play day in and day out. So ghrelin is the hunger hormone. it is released by the gastrointestinal mucosal cells when the person is ready to eat. So ghrelin, it aggravates hunger by stimulating the hypothalamic neurons. And if this hormone is higher, the food will be taken in. And that is taken care of by the hormone leptin. The leptin is released from the adipocytes and it promotes satiety. This satiety is very, very important so that we know that we don't need to eat more now. So any condition which leads to ghrelin excess or any condition which leads to leptin deficiency or resistance can lead to accumulation of fat in the adipocytes, and hence obesity can happen. So now we know why is obesity happening in our country and all other countries of the world, because of this disruption of this energy balance equation and disruption of the balance between the ghrelin and the leptin hormones. Now the child has become obese, let's say, and he is in our OPD. How to diagnose obesity in a child? See, for adults, though, we have cutoff values, the body mass index, which is calculated by weight in kilogram divided by height in meter square. This is body mass index. It is a very good indicator of overweight or obesity. In adults, we have a cutoff value, but it's not there in children because they are constantly growing. We cannot ascertain a value for BMI. So we have made these charts adapted from the CDC site. These charts show that whatever the BMI value is, we have to plot over these charts. These are separate for boys as well as for girls. The values which are coming in this yellow area, those children will be diagnosed as being overweight, and the values which will be coming above this yellow area and the pink area, those are diagnosed as having obesity. So apart from body mass index, are there other parameters with which we can diagnose obesity? Yes, we have parameters like waist circumference, waist hip ratio. These are in fact more sensitive for the central adiposity, which is rather more complicated one. So other things we can measure: waist height ratio, skin fold thickness, body fat percentage. But then why we take only body mass index for teaching purposes? Yes, because for children, the data, the charts, the measuring trends have not been yet prepared for other parameters, and it is available for body mass index. Hence, we can use body mass index as our treatment predictor. If we want to find out the etiology of adolescent obesity, first thing is it is very important to know the etiology of adolescent obesity. Why? Because apart from the other environmental causes or the excess of food intake and all, obesity can also be because of other internal causes, what we can say as pathological causes. Hence, exogenous causes, no doubt, are far more common. Around 95% of children are because of exogenous causes. Only 5% are there who have pathological cause for obesity, like endocrine disorders or syndromic obesity, monogenic obesity, drug-induced obesity. But it is very, very important to rule out those causes before labeling it as an exogenous cause for obesity. Exogenous obesity is primarily caused by obesogenic environment. That is the environment in which there are so much of factors which are prevalent, which have led the adolescents, our children, to change their lifestyle from a good traditional activity-filled lifestyle to a very sedentary sitting lifestyle. And also the increased or wrong food consumption is also one of the important cause for this type of obesity. We'll see in subsequent slides how this happens. This is a typical child, we can say, of an exogenous environment or obesogenic environment. These are the various factors which might have led this child to be in this state. Junk foods, frequently eating out and ordering the supersized portions of food, Parents are working, child has nobody at home to be supervised at. The advertisements which are shown in the media and which are endorsed by the celebrities, children, they get attracted towards those foodstuffs. There is no media literacy as of yet, and that is a very, very important aspect of the treatment at the community level, spreading the media literacy to children. TV, computers, internet, social media, video games, all these have made their lives so sedentary that they have no room for movement of their body even. Transportations have become so easy. Nobody wants to walk nowadays. So if parents are not walking, children are also not walking, and this has led to this state of affairs. Inadequate and unsafe playgrounds for children in most of the countries of the world. There is so much of academic overload at this age. The adolescents, they have to go to tuitions, schools, then tuitions, and then they have to self-study at home. So where is the time for activity? That is one other thing which needs to be discussed. Technological advances which have made the life even worse. Chronic stress leading to binge eating in this population. So this population, trust me, is in the more stressful state as compared to the adults. Their stress is of different kind. Their stress is regarding the friends, regarding their relationships, regarding their academic performances. So the stress is at different level in this population. They have low self-esteem, most of them. They sleep much less. The COVID pandemic has changed the ratio all over the world. So all these are contributing to the sedentary lifestyle, and this is what is called as obesogenic environment. This is leading to increased food consumption, wrong food consumptions, and obesity if the neurons are stimulated because of one of the reason or the other, either by a structural damage, by head injury, or a tumor and other genetic defects. These can lead to hypothalamic obesity. Then pituitary gland can have Cushing's disease, growth hormone deficiency, acromegaly. So these children are also obese. Hypothyroidism, pseudo-hypoparathyroidism. These children also have obesity as one of their cause as well as the effect. Pancreas, at the level of pancreas, there can be insulin resistance and there can be insulinoma, which is leading to increased insulin levels in the blood and hence increased adipocyte fat deposition. Cushing's syndrome, the adrenal glands, polycystic ovarian syndrome in females, and hypogonadism in males. These are the various endocrine causes of obesity that we have to rule out if indicated. Syndromic obesity is the one very important, less prevalent though, but it is very important to rule this out because treating this obesity would be a challenge for all the clinicians. Most common being the Prader-Willi syndrome. So in syndromic obesity, we need to, in every obese child rather, we need to look at the faces of the child. Like in Prader-Willi syndrome, the faces are typical faces with a narrow bifrontal diameter, almond-shaped palpebral fissures, triangular upper lip. So this corresponds to the Prader-Willi syndrome. We need to check for this, and then we need to follow with the treatment guidelines accordingly. Other syndromic causes might be pseudo-hypoparathyroidism, Lawrence-Moon-Beadle syndrome, and other such syndromes. The various drugs also can lead to obesity in children. So many children, they are put on long-term corticosteroids, like in those asthmatic patients, like nephrotic syndrome children, and for other reasons. Then the diabetic children, those who are type 1 diabetes mellitus, they are put on insulin. But if insulin inadvertently is taken in excessive doses, it can lead to obesity. Anticonvulsants, those children who are put on valproate or carbamazepine, they increase appetite of the child, and thus a lot of food intake is there, can lead to obesity. Other drugs can be tricyclic antidepressants, oral contraceptives, thiazolidinediones, risperidone, clozapine as antipsychotics. So all these drugs, their history has to be taken for all these drugs before labeling it as exogenous obesity. Monogenic obesity It can be a single gene mutation. It's an autosomal recessive inheritance. Example is pro-opiomelanocortin mutation, leptin gene mutation or leptin receptor mutation. And the monogenic obesity is most common in those children whose parents have been in a consanguineous marriage. So a very important history to be asked in an obese child, consanguineous marriage of the parents. Let's evaluate obesity now. We have found out the cause, we have discussed the causes, etiologies, and now how to evaluate on these lines. So we have to evaluate number one for etiology, we have to evaluate for the comorbid conditions, and we have to evaluate for the concerns. So let us take this one by one. For etiology, it was clear on the charts, the causes of the obesity which we have just discussed. Like we have to take a history, birth history. Birth history is very important. Even the maternal history before birth, before getting pregnant is also very important. That was the mother also obese? Was the mother suffering from hypothyroidism or diabetes mellitus? So all these history factors are very important in adolescent age as well. Age of onset of obesity is very important because in pathological obesity, typically its onset is before 2 years of age. And in exogenous obesity, typically its onset is above 4 to 5 years of age. Take the history for developmental delay, because pathological obesity is having, we might have children with history of developmental delay in these cases. Take the history of head injury, take the family history as well. How many first degree or second degree relatives they have this obesity or diabetes or other comorbidities in them. Take a good history of drug intake that we have just discussed. Lifestyle history is very important, and how to take the lifestyle history is very different in adolescents, and that we will be discussing in our subsequent slides. Dietary history, again, sleep patterns, all these need to be asked from the parents, from the child, very meticulously for diagnosing or for evaluating our child. Menstrual patterns history is to be taken in girls to rule out if there is any indicator for polycystic ovarian syndrome. And the psychosocial environment of the child at school, at home, at their activities area. So everywhere the psychosocial history. So all these we'll be discussing that how to take history, particularly in adolescents, regarding all these things. We have to examine our child. Okay, we have done our anthropometry, we have taken the body mass index, but again, look for the dysmorphic features, look for the Cushingoid faces. Sexual maturity rating is very important in all the adolescents, not only for obesity, but for every adolescent child. If they are entering your clinic, do sexual maturity rating, because we want to know what is the status of their puberty. Check for thyroid enlargement, check for hirsutism, acne, striae, and do a good cognitive assessment of the child. If you want to investigate, so what all are the tests which we have to do mandatorily in all the cases, and what all tests we need to do only if they are indicated. So X-ray for bone age is the one which is to be done in all the cases, because we want to know the bone age of the child. We want to know if the child is short stature or the age is matching chronologically with the child's real chronological age. And the TSH levels, they are also to be done in each and every child who are coming with obesity. Why? Because the thyroid stimulating hormone, it has a cause as well as an effect relationship with the obesity. Hypothyroidism can lead to obesity, and obesity per se can also lead to hypothyroidism. So let's suppose the thyroid levels have come lower side, or TSH has come to a higher side. So that doesn't mean that we have to start the child on thyroxine. We can motivate the parents and the child on this basis that if you want this thyroxine level to come to normal, you need to go for these lifestyle modifications, and this will get corrected spontaneously. So this can be taken as a tool for motivating for the behavior modifications. Then there are other investigations which are to be done only if there is a clinical suspicion, like ultrasound if we are suspecting PCOS, adrenal function tests will be indicated, growth hormone secretion test, function test, all reproductive hormones, serum calcium, phosphorus, PTH levels if we are suspecting hypothyroidism, MRI brain if indicated, if we are suspecting any hypothalamic or pituitary cause, and if you are suspecting any genetic cause, karyotyping, this will be indicated. So it's, in a nutshell, if we want to compare clinically exogenous and pathological obesity, exogenous, they have the age of onset after 5 to 6 years of birth, whereas pathological obesity has an onset early in life. In exogenous obesity, there is proportional increase in weight and height, but in pathological, the short stature is the hallmark of endocrine cause. The fat distribution is proportionate in exogenous obesity with a normal development, normal puberty. So SMR, if you do, that will come normal as per age. Bone age may be normal or mildly advanced in exogenous. There will be no dysmorphic features and they respond very well to the lifestyle measures. But in pathological obesity, fat distribution, you will find that it is disproportionate. More fat on the waist and less fat on the arms and legs, or more fat on the arms and less of it on the legs. So the disproportionate distribution is there, and they are more commonly represented with mostly central of adiposity. There will be neurodevelopmental delay or delayed puberty if there is any endocrine cause under away. Bone age may be delayed. Dysmorphic features we need to see. If there is hyperphagia, history of hyperphagia is very important. And they might have visual or neurological symptoms. So all these, they will correspond to the pathological obesity. This is just a checklist for syndromic obesity, that if a child is having developmental. So we have 5 Ds and 5 S for syndromic obesity: developmental delay, diminished intelligence quotient, diet abnormality, that is hyperphagia, dynastic history, like for example, family history, dysmorphism, or in the form of digital anomalies, and dysmorphism of the dome of it. So these are the checklists for syndromic obesity. If the swift onset of obesity less than 5 years of age, if it's a severe obesity, the child is having the sweet tooth, sanguineous marriage, suboptimal response to medical nutrition therapy, and sight or visual impairment. So this is just a checklist for syndromic obesity, which we have to look for in an adolescent child who has come up for the weight problems. So we can see this is a typical child who is having exogenous obesity. Why? Because this child is having a BMI of more than 95th centile. Growth and development have been normal throughout the childhood. SMR staging is also normal as per his age. Bone age is also normal, or in some cases might be mildly advanced. So let's say we found out that our child was having exogenous obesity. So now what? We have done basic investigations. We have ruled out the pathological cause of obesity. Next, the game is still not over, because we need to find out the comorbidities now. So what are the various comorbidities? We should know, and only then we can investigate for that. So this is a biopsychosocial model. Like, there are not only the biological comorbidities, there are psychological comorbidities as well, and there are social comorbidities as well. Musculoskeletal problems, mood-related, that is the psychological ones. So these are 8 M's in which I have categorized these complications. Menstrual problems, then there are other miscellaneous ones, the metabolic comorbidities, mirror-related, which are the cosmetic ones, monetary problems, and mitogenic problems. So what are the musculoskeletal comorbidities in these children, which we have to look for in every case of adolescent obesity? The first and the most important is slipped capital femoral epiphysis. Because of the heavy weight, the femoral epiphysis, it slips out of the acetabulum, and thus it causes an extreme hip pain, even limping in some of the cases. And if it is not treated, the bone grows in the same position, and that might lead to permanent disability if it is not treated and evaluated in time. Children can have genu valgum, the knock knees, which we say. This is because of the heavy weight, the medial side of the tibial head, it grows more than the lateral side of the tibial, lateral aspect of the tibial head, and this leads to knock knees. Blount disease can also happen. This is tibia vera condition, Blount disease. This is also very common in obese adolescent boys. Bowing of femur can happen. And in later stages, osteoarthritis can also happen. So all these diseases can lead to disability in children. So we need to evaluate for these comorbidities. Metabolic ones, we are all well versed with the metabolic comorbid conditions like type 2 diabetes, mellitus, hypertension, fatty liver, dyslipidemia, cardiovascular disease. So all these, they are, yes, they in last 2 decades, children also are developing these complications because of obesity. The youth onset type 2 diabetes is one disease which is being exponentially increasing in these 2 decades. The psychological comorbidities, depression, eating disorders, peer pressure, barobullying. Barobullying means the bullying which is because of high weight. So barobullying, social isolation, poor self-esteem, suicidal ideation, substance abuse. So all these comorbidities, they are really present in children. So for any chronic disease, we need to look out for these comorbidities which are affecting the psychosocial health of the child. In girls, we need to look out for polycystic ovarian syndrome. In mirror-related dermatologic comorbidity is hyperpigmentation or acanthosis nigricans. Then there are other miscellaneous comorbidities like obstructive sleep apnea. It's a very dangerous condition. So we need to ask in the history about obstructive sleep apnea, precocious puberty, serotumor cerebri, migraine. Migraine has been found to be associated with obesity in a lot of children, malignancies, hyperventilation syndrome, asthma. So all these are associated with obesity in most of the children. We cannot ignore the monetary comorbidity because treating an adolescent child will have a great health expenditure impact on the family, because for a bigger child, everything has to be bigger, larger size clothes, more of commuting because they cannot walk. So more of the use of vehicles will be there. So in this way, if we take in the small tasks, there is a greater health expenditure in the end of the day. And also the treatment for these children, because they need to be put on drugs sometime, and these are not very affordable drugs. So we have to keep in mind this factor for the family. And if we want to evaluate via investigations for these comorbidities, on the left side, we have those investigations which are indicated in every child, like X-rays of hip and knee joints. Obviously, for all those musculoskeletal problems, then liver ultrasound for fatty liver. We need to rule out diabetes by fasting and PP blood glucose. Lipid profile needs to be done, liver function, renal function tests, and last but not the least, TSH. Specific investigations like fasting, insulin, HbA1c, the calcium, phosphorus, vitamin D profile, reproductive hormones, genetic studies, PCOS, workup, sleeps, all these need to be done whenever they are indicated in a particular child. So let's now move on to a topic which is at another level for adolescents, because we have found out the etiology, we have addressed the comorbidities, but what about the concerns of the child? So what are these concerns? We can divide them into physical concerns, psychological concerns, and social concerns. Why concerns are so important? Number one, by venting out their concerns, an obese child will feel very much relieved with his or her internal psychological stress, because these children, they have no one to talk to. They hide some of the things from their parents, from their friends. So they need particularly an adolescent health specialist with which they can share all their concerns, because their concerns are not like adults. Their concerns are something which they cannot share with their close ones sometimes. So we need to have an ear to listen to their concerns. And number two, we can take advantage of these concerns in motivating the child later on. So we'll see how will that happen. First of all, the most important prerequisite for evaluating the concerns is our communication. How friendly are we as a clinician, as a doctor, with our little patient? So there are 3 C's which we need to take care of, like calm and composed environment. Yes, environment should be calm and composed, because if there will be a rush in OPD and will be noise here and there, the child will not feel comfortable in sharing his or her secret concerns. Compassionate behavior. You need to be compassionate with the child. Don't look at your watch again and again that it's time, it's time. We need to be compassionate, show empathy to the child so that he feels comfortable to share his or her views with you. Use a language which is comprehensible. Comprehensible means language which is appropriate for the age of the child, because an 11 or a 12-year-old child has a different mindset from an 18 or 19-year-old child, right? So language should be comprehensible. It should be salutogenic, means taking the child as a whole, not as my case of obesity. No, take the child as a whole, respect each and every aspect of the child. Being non-judgmental, be respectful to the child. We don't have to distract the child. No demeaning, no discouragements, and don't demonize. Even if the child tells you that he is being taking alcohol or smoking, so don't demonize at any of his or her concerns. Engage him in an empathetic manner. Encourage his little activities which he is showing in a positive manner, and keep him energized throughout the interview. So how do we evaluate those concerns? Will the child, after entering the OPD and we will ask the questions, will the child straight away open up? No, not at all. We need to proceed in a very tactful manner, in a very a good manner, so that the child starts opening up gradually. Because this is one of the tool, heads screening is one of the tool which is used globally. It was discovered, it was published in Contemporary Pediatrics back in 1988, but it is still being used globally. And this screening is composed of 8 components. The first 4 components, as you can see, home, education, eating, activities, these are general questions. These are general lifestyle questions for the children. But the next 4, drugs, about sexuality, suicidal thoughts, safety, these are very private questions. So first 4 will be used to create a rapport with the child, and the next 4 will be following the first 4. Like when we need to ask about the home environment. So one thing we should make sure is we need to ask only the open-ended questions to the child. So no questions which have a binary answer like yes, no. Do you like staying at home? Yes or no? No. This is not the way in asking the questions to an adolescent child while we are doing the head screening for their psychosocial lifestyle and environment knowledge. So like for home, you can ask that, can you tell me who all are living at your home, and who is the one in whom you can confide or you can share your secrets with? So you can ask this one so that they have an elaborative answer for this. Or who do you talk to whenever something is bothering you at your home? Then regarding education, we can ask that what is it that you like the most at school, or what is it that you like you don't like at all in your school, or what are your future plans like in education? Like, are you up to something, or you have plans to do something regarding your education? So let him be elaborative. Let him speak up, him or her. Let them speak up their mind. And you need to have a good listening ear. You need to have a dedicated time for that particular patient in your OPD. Regarding eating behaviors, you can ask that, can you tell me your whole day of meals, that how do you proceed from breakfast to dinner? Let him speak, let him or her speak. Or are there any times when you tend to eat more and then which is followed by a guilt of overeating? So you can ask like these. Then regarding activities, you can ask that, what do you do when you are free? What do you do with your friends after your school time? Or like, what are your hobbies? Do you which sports do you go to? Which sport you like the most? All these activities, like questions we need to ask. Then coming on to the next four concerns, these are very private, personal questions. So one prerequisite for these questions is you need to have a privacy with the child. So even the parents should also be requested very politely to move out so that you can talk to the child in a very closed environment. Because some things, some facts, child will not be able to speak up in front of even their parents or guardians. Like if you want to ask about drugs, so you have built a very good rapport with the child, you are being empathetic throughout, the child is starting to open up with you, then start asking these questions. Regarding drugs, you can indirectly start from there with the friends, like do some of your friends or any of your friends are in drugs or smoking or alcohol habit lately, and what do you feel about it? Or have you ever been peer pressured by your friends to try some of these things, and how did you feel at that time? So you can ask these things. Like regarding sexuality, you can ask that, example, mm, are you in any romantic relationship lately? How do you feel? Are you in any physical relationship lately? How do you feel? Or have you ever been depressed or sad in all these recent days? Or whenever your friend is sad or depressed, how do you take care of your friend at that time? And safety. Do you feel safe at your home or school or tuition or your activity area? How safe are you? Who is the one person you will go to when you don't feel safe? Or what do you mean by your own safety? So asking these questions, which will which will evoke the child to speak up, to vent out their concern, will this the half of the motivation part is over with this screening tool itself. So we have done the height screening. Now, how to proceed for the clinical management of adolescent obesity? Because discussion of this is very important as far as adolescents are concerned, because it's a way different from those adult people whom we can say that yes, you have to exercise, you have to eat healthy, and then prescribe some of the drugs for to them, then they can then we need to we need to explain them the comorbidities, we need to explain them the long-term effects. They might understand and they start doing all these things. But it's not a cakewalk in adolescence. Their mind think differently. They don't think long-term. They don't know that they have to take care because they might develop diabetes later. No, they don't know that they might develop bone problems later, so they have to lose weight or they have to go for behavioral modifications. No, it's it has to be done in a tricky way, involving the family as a whole. Because if we ask the parents that your child needs to eat healthy, he needs exercise, and the parents, they just employ at home that you don't need to eat this. You are eating ice cream, the child doesn't have to eat ice cream. So how will this go? Not at all. Family as a whole needs to undergo that behavioral modification, and it's our responsibility as clinicians, as doctors, to convince the child as well as the family for this major step in their lives. So these are the three clinical pillars. If we go on to manage obesity in a child: behavioral interventions, pharmacotherapy, and later on surgery. So we'll discuss these one by one. For this management, we need to set some objective targets, the end point of our management. Like there should be a gradual and sustained weight loss of 0.5 kilos per week. 7 to 10% weight loss should be there over 6 months, not more than that. And we need to avoid a loss of over 1.5 kilos every month. So the target should not exceed this one. So it should be a balanced modification. For behavioral interventions or behavioral therapy, We all know life's physical act, all know. But is this sufficient for an adolescent child? No, not at all. We need to employ certain tools for behavioral therapy, especially in a child. We can use them in adults as well, but convincing an adult is way more way easier than convincing an adolescent child. So how do we do that? What magic which we have to create over the child, that the child himself or herself is ready to change for her own good. So one of the most important tool which is used worldwide is motivational interviewing. These are the four, we can say, processes through which we proceed in motivational interviewing. First of all, what is motivational interviewing? It is a technique, or we can say a tool, with which we as clinicians, we are just the listeners, and our patients, the adolescent child or a child, they are the speakers. Means they will speak out by themselves that what are they suffering from, what is their problem, and even their solution. Yes, with this tool, the solutions are also being spoken of by the children themselves. So this is the magic of this tool. How do we proceed? First of all, engage the child. So that is already being done with the head screening. We have already engaged our child in a general manner. Now we need to bring the child's focus to our area of concern, that is his weight. So bring the focus to his unhealthy lifestyle, unhealthy eating habits. So bringing out the focus, and then evoking the child to speak up by himself, that how is it possible for him or her at his or her convenience to bring out that change. So the change and the idea of change is also to be brought up by the child himself or herself. So we need to evoke it out from, we need to extract it out from the child's own minds. And then lastly, plan with the child, plan in a collaborative manner, that what can be done or what cannot be done, which is convenient for his or her lifestyle. So these are the four processes of motivational interviewing. So before discussing in detail about motivational interviewing, I want to present a model which I have devised, and it has been published back in 2023, a 3-level MI model. It has 3 levels of these are the techniques with which we proceed with the child's behavioral therapy. Level 1 is the motivational interviewing only, which we have just discussed, and we'll be discussing in detail later. Then the motivational induction is the level 2, and motivational intensification is the level 3 of this therapy. And it has to be a family-based approach. Like I said before as well, that whole family has to be together, and we as clinicians also have to be the part of that family. So what is motivational interviewing? The level 1, when is it is instilled? That when the child has no insight, that is level 1. Child doesn't know I'm obese. Child doesn't know that something is wrong with me. So motivational interviewing is instilling the seed into the child that yes, something is wrong with you, my dear. So this, at this level, motivational interviewing is done. When the child has insight but lacks motivation, child knows that something is wrong with me, I am fat, and that's why people make fun of me, but they lack motivation, they don't want to change, they think that they can't change. That is where motivational induction level 2 steps in, and we need to intensify that motivation. They are motivated, but then after a week or 2, they lack their consistency. They again get demotivated. So this is where the level 3 steps in. So again, coming back to the level 1, motivational interviewing. These are the techniques which we employ to take out that seed of motivation into them. So first of all, what we should do is engage them with empathy. Yes, we are discussing it time and again that, yeah, engaging them with empathy is the first step if you want your child to start changing his behavior. Understand the child. Understand the child means every child is different. Yes, you need to understand his or her concerns. That's what we had done in the head screening. OARS means these are the techniques with which we can employ all these thing, empathy, understanding. And so OARS means O is open-ended questions. Yes, in head screening, we have asked open-ended questions. A is affirmations, very important. If you feel that child is not that self-sufficient, child thinks that he or she is, he will not be able to do that, give him or her affirmations. I am strong. I can do that. You have a strong willpower. Or he can do self-talks for that matter, that I am strong. I can do it. I have that much willpower. And R is reflections. Speak with the child. Like if the child says that I can't help myself, I can't control myself from eating burgers and pizzas. Reflections means reflecting the child. Yes, I agree. Whenever the food like pizza and burger is in front of you, you can't control yourself. I know it's very difficult. I know. So speak whatever they are speaking. Reflections is that great, has that great power with which the child believes that you are you have entered his or her shoes, and he will now be wanting to change herself or himself. S means summarizing all the things which the child has said. The child will feel heard, will feel listened, will feel concerned. So this is a magic tool, OARS, to bring the child on your side. While talking to the child, must replace all the hurtful terms with more comforting ones. Like don't use obese, fat, overweight. Use unhealthy weight. The word unhealthy, it sounds scientific. Use unhealthy and it doesn't sound hurtful or being judged at. Then don't use junk foods or bad foods. Use unhealthy food, non-nutritious food, like these terms. Then don't use exercise. Exercise is a way, a hurting term, like why should I exercise? We can use playing, we can use fun activity, fun time. So these will be more fascinating terms for child to be heard. We need to support self-efficacy. What does that mean? The children who, if you find that the child which you are tackling with is has a low self-esteem, so support that self-efficacy. No, you have that strength, you can do it. A little spark in the child, support that spark. Resolve the ambivalence, means when the child is in doubt, I don't think I can do it. If I'll do it, I don't think I'll be able to continue it. So resolve that ambivalence by developing discrepancy. This is a magical tool. Develop discrepancy. Take out a paper and a pen. Write down the current habits, the unhealthy habits of the child. Write down the desired healthy habits of the child. Present in front of him the benefits and risks of those present behaviors, and the benefits and risks of the desired behaviors. Develop this discrepancy in the mind of the child. The child will see the things in front of him or her, and this will ignite his mind. So in this manner, and there is another one technique which is employed is rolling with resistance in motivational interviewing. Means when the child resists the change, child denies the change, don't argue. We don't need to argue. We need to roll with this resistance. Like just be with them, be with him or her, that I know you are afraid, scared to it, but let's give it a chance. So in this way, without being judgmental, just roll with their resistant mind. Apart from this, apart from talking with the child, parental counseling is also very important, because a home environment, if it is not healthy, the child will not like to continue that the behavior for long. So create a healthy home environment at home, not using any abusive language, not scolding the child for not doing whatever we want to let him do. So a healthy home environment, positive talks should be there for the child. So once you feel that yes, the seed of motivation has been instilled into the child, give them the appointment for level 2. Don't we know we don't have to rush for level 1 and then in the same sitting level 2. Avoid that. Give an appointment for level 2. Give the child time to think upon himself or herself. In level 2, we do motivational induction. We start the activities of the things like, and this motivational induction in this level, family has more important role to play. We need to counsel the family members that what you can do at home so that child eats healthy and the child keeps on moving his or her body without him knowing that he is actually moving his body. So these are just sneaky ways to let the child do physical activity. First and foremost is ask the parents that they should use mindful conversation at home. Don't use that you are getting so heavy, you have to run daily. So saying this thing to the child, it will hurt his or her sentiments. So mindful conversation is only good. And family members should behave as role models for the child. So go for walk yourself if you want your child to go for walk. So go for a dance class with your child and take your child to the grocery shopping and shop all the healthy food items, all the fruits and vegetables. Stop eating junk food yourself, the parents, if you want your child to stop eating junk food. So like this role model, being a role model for the family is very, very important. Create a physical activity hour in an activity area at home, like a backyard, where this 1 hour will be particularly our activity time, activity hour, and this is our activity area. No screens are allowed in this area. So make a rule, because children abide by the rules. It's there, it's in them, it's in their minds always. So bring the sneaky ways to keep the child active. How can we do that? Park your car lot far away from the shop which you need to go, and go to the shop walking. So this is a sneaky way to keep the child active. Create a stair climbing race with the child in this manner. Then you can use some hacks for screen reduction, like taking them to an outing. Weekend outings are a very important technique to reduce screen time. You can lead the child join any sports activity, so screen time will be reduced automatically. Healthy food hacks. Tricolor plate is a very good idea, especially in India. What we do is we present a plate which has 3 colors as corresponding to our Indian flag: orange, white, and green. So a plate with 3 colors of food, it is very fascinating for the child. So it instills in them patriotism as well as a hack for a healthy food. And then give an appointment for the level 2, level 3, motivational intensification. Intensify. How will we intensify? How will we make sure that the motivation will remain consistent in the child? Foremost technique is constant appreciation. Just even for small achievements, appreciate the child. Even if they have lost few grams of weight, appreciate the child. If they have crossed 1/4 of the ground, appreciate the child. We should award them with big rewards for little changes. Like any little change, give a big reward. But no, rewards are not to be the desserts or pizzas. Rewards should be taking to an activity trip, or taking to an adventurous trip, trekking activity, or buying them roller skates. So these are some of the big rewards. Let them join their sports program of interest. And we should appreciate the achievement of qualitative goals. If your girl has been able to lose that much weight that the previous dress is now getting fit in herself, so appreciate that achievement, celebrate that achievement. Ask the parents to break the goals into sub goals. Like if they have to cover the whole ground, so first goal is to cover half of the ground without a break. So breaking into sub goals will keep the child motivated. We can install the activity tracking apps in our phones. So seeing the scores, the activity scores will motivate the child. And last but not the least, keeping a positive environment at home, at your clinic appointments is a very important move. So these are just some of the guidelines which have been put up by American Academy of Pediatrics. These look fascinating for a child, so we can show them to the child, like 5-2-1-0 rule. Five fruits or vegetables to be eaten, reducing the screen time to 2 hours a day, playing for 1 hour, physical activity of 1 hour daily, and 0 sugars and beverages. The green light traffic light system is also has been adopted from the American Academy of Pediatrics. Like red light means watch out when you have to eat a higher energy density and eating small amounts only of those foods. Yellow means just slow down for medium energy density foods, and green light means you can go for lower energy density foods. So showing these colorful charts to child, they become memorable in their mind, and then they take it for sure. The plate size which is recommended for everyone is for adults. For children, 7-inch plate size is recommended. Of this, half of it should include vegetables, 1/4 should be protein, and 1/4 should be starch. Then this is the plate size which has been recommended by P. So how magically we have done the behavioral therapy of the child, and this I am doing at my OPD for last 1 year for my children, and they improve. They definitely improve, and it's seldom only that we need to put them on some of the other drugs for obesity. When should we start pharmacological treatment? If the BMI, the cutoff level goes beyond 30 with a weight-related complication associated, or if severe obesity with BMI of more than 120% of 95th percentile, or 35 BMI of 35, even if there is no comorbidity or complication. And for every drug, we need to consider and discuss side effects and tolerability. These are the various drugs which we can use, but still now they are being FDA approved for only in adolescents more than 12 years of age. And with these drugs, lifestyle modifications still need to be continued. Liraglutide, show dose is 0.6 milligrams subcutaneously once a day. Increase it weekly. Maintain its dose 3 milligrams subcutaneously once a day. Orlistat, 120 milligram orally 3 times a day with a fatty meal. Semaglutide, 3 milligram orally once a day. Monthly increments with the maintenance dose of 14 milligram once a day. Phentermine is approved only in more than 16 years of age. Surgical therapy is rarely indicated. It should be discouraged as far as possible. Only with the children who are having severe obesity with BMI of more than 40 or more than 35 with complications. And it should be advised only after the completion of linear growth of the child, like 16, 17, 18 years of age. And we need a multidisciplinary obesity team with a long-term follow-up. Still, we need to be maintained with extreme motivation, strict diet, and activity schedule. So those lifestyle modifications will not leave the child's hand. They have to go along with every mode of therapy. So like we said, we need an integrated obesity care for a child. We need a dietitian, especially we need a clinical psychologist sometimes. Family members support is or should be there ongoing. Women might need to refer to specialist services whenever needed. There are certain patient support groups. We need to enroll them in those patient support groups. We should do a proper risk assessment of the child. An exercise physiologist is must, or we can club them with professional trainers who can train them the exercises which are required. A practice nurse is required, medical therapist, bariatric surgeons. So an integrated care is needed for these children. So this is my friend octopus. Like an octopus has 8 legs, or this my friend octopus whom I've named as Omni. This Omni is a female octopus. She is giving us 8 take-home messages for adolescent obesity. That first of all, make sure that adolescents are not little adults. We don't have to treat them like adults. We have to treat them like adolescents only. They need a sensitive, person-centered care, a holistic care, not a case approach-based care. They need family support. They need intensive behavior therapy, like we discussed. Healthy home environment is the mainstay of their consistent lifestyle changes. Multidisciplinary approach is imperative for them. We need to identify comorbidities in each and every child with obesity. And last but not the least, prevention is better than cure. So obesity should not happen in the first go. So since birth only, we as pediatricians, we counsel the parents since birth only that what all they can do so that their child doesn't land up with obesity in later years. We cannot treat the body without listening to the story the mind and environment are telling us. Thank you. I must stop sharing. Yeah.
Thank you, Dr. Verma, for a wonderful, in-depth, and very knowledgeable presentation. I would like to open the forum for question answers. Please, if anybody has questions, please come forward. I think it's a very important topic and definitely it needs time. So,
yeah, thank you, Saurabh. Excellent presentation. Dr. Verma, you cover almost everything. I have few concern and I have few patient, and it's difficult management. One is that it's a Down syndrome, hearing and speech impairment, and it's an hypothyroidism. And the patient is just eating when everybody is sleeping. Whatever available is so difficult multitask team to manage. So what is your advice on Down syndrome, how to manage? And the other question is, the infant who is born large for gestation, are they become obese in the adulthood or adolescent? Those are my concern. Thank you.
Okay. Thank you, Dr. Akhtar. Actually, the Down syndrome patients, yes, we need a lot of support. So there should be an integrated team for such children. It's very difficult to manage. Yes, I agree. These children, yeah, and more so when they are having hypothyroidism associated, and it's difficult to convince those children. So we have to involve the parents along. We have to involve the speech therapists, the psychological, clinical psychologists in our arena. We need to take their help so that they communicate with the child on our behalf that what needs to be done. And parents play a much more important role in managing such children. And for second question here is that large for gestational age babies. Yes, they have a propensity to develop obesity in childhood as well as in adolescents, which might go on to the adult phase as well. So we need to take precautions early in life. Exclusive breastfeeding is the one method, is the one very important preventive method for preventing obesity. So convincing mothers to exclusively breastfeed these children and then giving no sugar till 2 years of age. No sugar till 2 years of age will prevent sugar intake, sugar addiction in children in later life. So these are some of the preventive methods which we need to inculcate in the mother in earlier years and then in the child in later years. So that's how we can help those children.
Thank you so much, Dr. Verma. Thank you.
Well, thank you very much, Dr. Verma. This is Dr. Alvin Chen from Hong Kong. And thank you very much for the excellent talk. I I am a pediatrician as well. And well, I have a couple of patients who have been diagnosed with Prader-Willi syndrome. The children began with small, birth weight, but then they have small fingers, tiny fingers, and then also short stature and obesity, all right, central obesity. And and they have been retarded mildly. One is mildly retarded, one is moderately mentally retarded, and also with some behavioral problem. You know, very emotionally volatile, and well, but well, of course, they need to study in special schools. All right, and so of course, for these children, for the motivational and um, advice for them to keep on the diet and exercise is very difficult. All right, and what's your experience in having growth hormone therapy for these children? Would they help besides the growth in height? Would they help in the management on obesity as well for them? And but of course, because of the chromosomal deletion of the 15 chromosome, they had genetic makeup for the obesity. So I guess we in Hong Kong won't give the injections of the diabetic medicine, which is also quite expensive and yet not really that scientifically proven to be effective in Prader-Willi syndrome yet. All right. So what about growth hormone? Also very expensive. But do you think you would also use growth hormone for them? Thank you.
Thank you, Dr. Elvin, first of all. So being a pediatrician, I can understand your dilemma. Yes, Prader-Willi syndrome children, they are difficult to manage because they are mentally retarded most of the times. And growth hormone, if we can, first of all, we, again, in these type of children, we need an integrated approach. We alone cannot manage them. So a geneticist is required, an endocrinologist is required, and I think we should do a growth hormone function test in these children. And if it comes deficient, we should definitely treat them with growth hormone if it's affordable for the family members, because we need to take into account the family income also into this. And with an integrated approach with all the specialties involved, we should make the decision collaboratively with the family.
Yeah, so we have to, of course, refer them to either university or government institutions for treatment, because in private clinics, and it's quite often not affordable for usual families.
Exactly. That's what I'm saying, that we need a full team of doctors for these type of children. We alone in our OPD can't do that.
Yeah. Thank you very much, Dr.
Thank you.
Thank you. Thank you, Saraba, for the very nice session you had arranged for us.
And definitely a nice session which brings Elvin on the board after very long. Thank you for joining. So anyone else has a question, please go ahead and ask. Okay, so we just have comments from Dr. Monica. She was joining in from US, and in the interest of time, she had it was very late, so she has to leave the presentation at the last moment. But she says, "Thank you, Dr. Verma, for a great presentation. I have to sign off right now. Great information on ghrelin and leptin. The use case from Delhi. Would love to hear a follow-up on the case and the motivational interview. Looking forward to see how the use of obesity medication can reduce the expected obesity rate in the adults, and how we can manage the obesity promoting culture." So these were the comments from Dr. Monica Vasudev. So I believe we don't have any more questions on the floor. With the interest of time and the great knowledge which we shared right now. We would like to close the presentation and thank you, Dr. Verma, for giving us immense knowledge about it. We would like to have a follow-up session about it after a few weeks. With this note, we would like to close the presentation. Thank you, Dr. Verma.
Thank you so much. Thank you so much for inviting me, for having me here to share my views and to meet all such dignitaries present here. Thank you so much.
Thank you, CMAAO, for joining in, and see you again next time. Thank you.
Thank you. Thank you so much.